I'd like to welcome everyone for the first NED, the Northeastern District webinar and forum on silver diamine fluoride in cooperation with Tufts Pediatric Dental Department. We're going to have a short presentation from our president of the Academy, Dr. Miller.
Hello, everybody, and I'd like to welcome you for this really innovative approach as you're venturing into a whole new area of education with the district. And this year, my whole year's been based on relationships. That's what I think is, as we all know, is so important, whether it's with our families, our friends, but also with our professional colleagues and our patients. So I appreciate an opportunity to speak with you and introduce this kickoff of this innovative idea. I'd certainly like to thank several people to make this all possible. First is George Cisneros, the current president of your district, as well as Bob Moreau, the immediate past president. Two other critical parts of this puzzle are your current trustee, Dr. Devin Schroff, and the past trustee, Dr. David Tassini. So thank you for your vision of how this could change education in your district. As many states and district as well as the national, our AAPD, look at ways for education, there are a number of different approaches that we've taken, from looking at webcasting at the national level, as well as some states and districts doing the same thing. As we know, in the Northeast District, it's founded on a lot of strong educational conferences, two of those being the Greater New York meeting, as well as the Yankee meeting in Boston, which are two of the biggest and strongest in this country. Now we're looking at a whole new approach, and that's the virtual NED. And in that virtual NED, it offers many advantages. Economically, there's no cost for hotels or restaurants or transportation, but really in your own community, in your own home or office, you can take place in this educational opportunity, not only with yourself, but perhaps with your staff as well. I want to really acknowledge the Northeast District for this innovative approach to dental education. And I certainly want to wish you the very best as you move forward. It couldn't have been possible without Tufts University and the dental school and the generous and hard work of Dr. Chin Liu as a professor and chair of the pediatric department, and the hard work of the graduate students as they prepared the white paper, as well as are monitoring this forum. So those are the critical pieces that could have made this possible. So as we move on into this next future, we all look forward at the AAPD not only to the success of this meeting, but also could this approach be used by other conferences in states and districts? So I wish you the best, and thank you all so much for letting me be part of this.
Now I'd like to ask Dr. Cisneros, the president of the Northeast Pediatric District of Pediatric Dentistry, I got that wrong, to say a few words for us.
Thanks for coming, and thanks for watching. Just to tell you a little bit something about the Northeastern Society of Pediatric Dentistry. We've been in existence now for a little over 20 years. It was a group of individuals that met somewhere in the Berkshires in Connecticut in the early 90s. It was Bert Edelstein, who was the outgoing trustee at the time, and I, the incoming trustee, along with Don Greiner, Bob Frank, and Lois Jackson. And around that time, we formed a group from all the Northeastern group. At that time, it was District 1, being New York and the New England states and the southeastern provinces. In recent years, the two districts have been combined. Two districts being District 1 and District 2, the Middle Atlantic states. And so we're now launching this new initiative, the brainchild of David Tassini, current parliamentarian and former District 1 trustee. And also Bob Moreau, the immediate past president of the Northeastern Society of Pediatric Dentistry. I thank them for giving us something to do with the new leadership. It's myself, Angela Stout, Adam Silovich, and also Devin Schroff, who's the new district trustee. As an academic myself, when I first heard about this, I thought it was a wonderful opportunity to bridge between the practitioners and our academics. The Northeastern District, NESPD, District 1, is nearly 1,600 members. I think that makes us close to the second largest district in all of the academy. We have 17 dental schools, which is a little over a quarter of all dental schools. We have 37 postgraduate programs, which is close to 40% of all postgraduate programs in this country. We have tremendous resources, and it's exciting to be able to give you our first virtual NED, Virtual Northeast District, and along with the help of Tufts, Continue Education, and Dean Thomas, I appreciate his help as well. We're able to give you our first VNet on silver diamine fluoride. And our speaker tonight is Dr. Cheen Liu, professor and chair and program director. That's the real job. I don't say that lightly. Who's going to be giving this presentation tonight. Cheen?
Welcome, everyone, to the inaugural Virtual NED. And I'm very honored to have been chosen to give this very first webinar for our group of members that will be logging on and reviewing this with us. So we are going to talk about silver diamine fluoride. What is its place in oral health care? So when you have completed this webinar, you should be able to identify the FDA-approved indications for SDF, describe its mechanism of action, list the contraindications for SDF, and the precautions needed during SDF application. So silver has been used since 1000 BC for storage of drinking water, and it's currently used in medicine for its antimicrobial actions. For example, we have silver foil, silver nitrate, silver sutures, and ointments containing silver, and catheter linings that contain silver. Some of the examples that have been used historically have been antimicrobial ointments for prevention of infections in burn lesions, silver nitrate for ocular infections, hip replacement parts that are made of silver, and wound dressings that contain silver. It has also been used in dentistry for over a century. In the early part of the 20th century, many of our esteemed dentists have used it to arrest carious lesions. The silver nitrate solution was known as Howe solution after Percy Howe, who was at Forsyth and also a previous ADA president. If you look at this issue of JADA from 1939, it talks about the Howe solution introduced in 1917, and it's used for caries in primary teeth. And more recently, in 1981, Craig and his colleagues published this paper in Australia regarding the use of silver nitrate in primary teeth. And I was fortunate to be in dental school in Sydney when Dr. Craig was a faculty, and I remember having my pediatric dentistry rotations, learning how to place silver nitrate on deciduous teeth to arrest caries. So we fast forward to 2009 in Boston. This review was published by Richard Nederman and his colleagues when they were at Forsyth, and they identified 2 very good clinical trials that compared the effectiveness of silver diamine fluoride and fluoride varnish in caries prevention. So what they found was silver diamine fluoride was far superior than fluoride varnish in caries prevention, 70 versus 55%. And in terms of caries arrest, silver diamine fluoride had a 96% effectiveness compared to fluoride varnish, which was much lower at 21%. And they concluded that SDF is more effective than fluoride varnish. And a meta-analysis published this year also concurred, and they reported that 2/3 of all dentin caries lesions were arrested after being treated with SDF. Since SDF is a new chemotherapeutic option, FDA approval is required. In August of 2014, FDA approved this for treatment of dentin hypersensitivity, and it's since been used off-label for caries arrest. And the more exciting news recently is that SDF was granted FDA designation as a breakthrough therapy for the arrest of tooth decay in children and adults. This designation is a way for FDA to expedite development and review of new options to treat serious conditions. And we look forward to obtain FDA approval for this actual indication. So what is SDF? It's actually a colorless liquid that has a pH of 10. It's 38% silver diamine fluoride. So 25 to 29% of this is silver component, and 5 to 6% of this is made up of the fluoride ions. The silver in SDF acts as an antimicrobial, while the fluoride promotes remineralization. The ammonia in the liquid stabilizes this solution in the high concentrations. So the advantages of SDF is inexpensive, non-invasive, and easily applied on the carious lesions. So what are the mechanisms of action of SDF? When applied to the carious lesion, it forms a black layer indicating caries arrest. And the silver protein conjugate layer is more resistant to acid dissolution and enzymatic digestion. The silver component, as we mentioned, is bactericidal and interferes with multiple functions of bacteria. The SDF has anti-enzymatic effects. It inhibits cathepsin B and K and matrix metalloproteinases. All these enzymes play a part in degrading dentin. So therefore, it helps with a tooth with decay. When you look at the rectangle on your right, it represents a tooth with a carious lesion. So when silver diamine fluoride is applied, the hydroxyapatite is converted into fluoroapatite, which, as we know, is more resistant to demineralization. The silver phosphate that precipitates on the surface of the caries interacts with different parts of the bacteria and causes the antibacterial effects to take place. So this picture shows pre and post SDF treatment of carious teeth that we have mounted in plaster. And if you look at a closer image, this is SEM images published in 2014. On your left is the carious lesion that hasn't been treated. And on your right, when you look at the same lesion that has been treated with SDF, you can see the tubules are occluded and the dentin layer is much more matte, and we don't have the dentin collagen fibers sticking out of the surface. So what happens when you place the SDF on the lesion? When you look at the hardness of the actual lesion, on the bottom scale, 0 is the surface of the carious lesion, and then if you go further to the right, it indicates the deeper parts of the lesion. When you compare treated versus untreated lesions, the soft caries is present on untreated lesion right at the surface. If you follow the blue line, it has a lot softer surface compared to the deeper parts of the lesion. When you look at the treated lesion represented by the red line, you can see that the surface has become a lot harder than an untreated lesion. And if you look at the scale distance from surface, you can see the SDF penetrates up to about 200 microns from the surface of the lesion. And in comparison, I just want to remind everyone, if they don't remember offhand, that sound dentin has a noob hardness number of about 68, while sound enamel is in the about 350 region. So it has significant effect after SDF treatment, but if you go deeper into the lesion, it becomes more similar to the untreated lesion. So what are the clinical implications? We can use SDF for caries prevention, for example, on permanent first molars that we are not able to seal, for caries arrest on cavitated lesions as a desensitizing agent, and it has a potential to be used for indirect pulp caps and possibly for root canal irrigation, since it has the antimicrobial actions. So how do we use it in clinic? The only product that is cleared by FDA so far is Advantage Arrest, which is produced by Elevate Oral Care. It is 38% SDF, comes in an 8 ml bottle, and the current listed price is $129 per bottle, and you will get about 250 drops from each bottle. And that means we can get up to about 125 applications, since we use about 1 to 2 drops per application, and each application means up to 5 teeth on the same patient at the one visit. And the procedure billing code is 1354, and it's for interim caries arresting medication application, and it's defined as placing this on a non-symptomatic caries lesion and without mechanical removal of sound tooth structure. So some of the indications are patients who are pre-cooperative, for example, are very young patients that have severe ECC, and patients that have behavioral issues, and sometimes the patients have logistical challenges, such as financial challenges to obtaining care or accessing care for definitive treatment, and patients who are medically fragile. This means sometimes we have patients who are immunosuppressed, and it's inappropriate to place definitive restorations at certain times during this patient's medical conditions. Here we have some examples of patients that we have treated. This patient was seen pre-op, and we have taken a bite wing before the SDF application. And this shows you the view of the teeth before the application, immediately after, and also at 1 week follow-up, where you can see the black staining has increased after 1 week. And currently this patient is on the wait list for treatment under general anesthesia. Another example is a patient that we applied SDF about 2 months before treatment under general anesthesia. And then we followed up by treating this patient about 2 months later, and these are radiographs taken in the OR. Another indication is for patients that have severe medical conditions. This case report shows a 14-year-old patient with chronic oral GVHD post-bone marrow transplant. And this is what the patient presented with after 3 years of no dental treatment at all. So every single permanent tooth has caries. So in order to alleviate the sensitivity and also to control the rampant caries, the SDF has been applied. And following that, this patient received progressive treatment in order to address the restorative needs and the endodontic treatment needs as well. Some of the contraindications for SDF is if the patient has silver allergy or any sensitivity to silver or any heavy metal ions, the presence of any stomatitis or ulcers intraorally, and if the tooth has been symptomatic or have potentially pulpal involvement. For example, it could have a fistula or it could be necrotic. So what's our armamentarium for SDF treatment? We need eye protection. We also provide petroleum jelly to protect the gingiva adjacent to the area of treatment. And we have the bottle of SDF. And we apply that with a microbrush from a disposable Dappan dish. And we also have cotton rolls and 2x2 for soft tissue isolation. So the technique is very straightforward. You dispense 1 to 2 drops of SDF into a Dappan dish, and you isolate with cotton rolls, or you can also use petroleum jelly or rubber dam. And you use the microbrush to apply the SDF onto affected caries lesions and allow it to absorb about 1 minute. After that, we can remove excess with gauze or cotton roll and air dry. If the SDF contacts any other soft tissue, we should rinse the area thoroughly. We have to remember to use appropriate PPE and also to make sure that when you dispose of the material that it is put away pretty carefully because it can stain skin and also your countertops and benches. So do we need to reapply SDF or is the one application sufficient? When we look at the literature, it shows that if you reapply it every 6 months, it maintains the caries arrest to above 90%. If you drop it down to an application every 12 months, your effectiveness goes down to below 80%. So the recommendation is to review every 6 months and reapply if that tooth is not getting a restoration. And what are the risks when you apply SDF? Since it contains almost double the amount of fluoride in varnish, we should avoid applying the SDF and varnish at the same visit. And what are the risks of ingesting SDF? So when you look at the LD50, we have seen that what we use has a 500-fold margin of safety. The recommended limit is to use about 1 drop per 10 kilograms to treat up to 5 teeth in the same patient per visit. And we should have at least a 1-week interval between applications for the same patient. Can the black staining be reduced? That is one of the main concerns voiced by parents. So SDF will permanently darken the carious lesions, but not sound tooth surfaces. There is a development by one of the other companies to apply potassium iodide, which has been shown to produce a white-silver iodide reaction. And Riverstar is the product that is currently going through the process for FDA approval, and it's produced by SDI, a company from Australia. So it comes in two components. The first unit is SDF, and the second is the potassium iodide that once it's applied to the darkened surface will reduce the staining considerably. So who can apply SDF? So currently, the Oregon State Board of Dentistry has ruled that it may be applied by dentists and dental auxiliaries, meaning hygienists and assistants. But in many states, it's still unclear who other than dentists are credentialed to do so. And finally, I would like to thank the NESPD and AAPD and our 3 residents who worked on this, Azita, Salafa, and Movarit, and all our other residents, and my colleagues that are here today and who have communicated with us to provide valuable feedback during preparation of the paper and of the webinar. Thank you very much.
Maybe people have questions
Yeah,
themselves, right?
yeah. So in any case, we'll start off with just how many people have used the silver diamine fluoride? So about maybe half to 2/3 of the group. What the people who are using it, what are the uses what are the situations you're using it in? Can I have some, comments or? Yes, sir.
I've used it successfully in cases where a young child with early childhood caries and open caries lesions might otherwise have had to have been taken to the operating room to do procedures under general anesthesia. I've been able to buy some time by applying the silver diamine fluoride with the parent's knowledge that the lesions are going to turn black. But for many parents, that decision is easy to make because they don't want the kids to have general anesthesia. That's often why they want it in my office. And the alternative of being able to buy some time by applying the silver diamine fluoride treatment and arresting the caries is one that parents are very happy about.
Any other specific times or ideas when you would use it?
Special needs. Special needs population.
Special needs population. You're talking about kids that whether you have to go to the OR or sedation, etc. So trying to do some early treatment with special needs with the young kids that have to go to the OR. And even going to the OR nowadays, it could be 4, 5, or even 6 months at most of the dental schools to get a patient in. So at least it kind of stops the clock on the caries and just helps you have a lesion that is not into the pulp. And are people doing restorations after these if it's a patient that doesn't go to the OR?
I did one.
Yep.
Yeah, glass ionomer.
Glass ionomer? Yeah. Is anyone using any specific materials? I know that John has used Activa. I've seen a number of people use Activa for after a period of time to do some restorations on it, or glass ionomers. I think that the media has put it out a lot that this is a miracle thing and you can go put it on and then just forget about it. And it's not one of those things. It's something that needs to be monitored, has to be looked at. It's effective, but depends if you do it once or twice, 70, 80, 90%, but there's a certain amount that will fail and caries will progress. So it's a matter of when it's used, it's not just use it and forget about it. It's following up whether it's a month and 6 months and down the road to make sure that everything is arrested. And is everyone using a medical form or a consent form? Yeah, I think one of the most important things is to let people know that, and to make it very clear that it's something that needs to be done, but we're doing it and has to be followed through. That most kids that are 2 or 3 that will have these lesions done will need some kind of additional treatment, whether it be more arresting solutions or some kind of restorations down the road. Has anyone used it for interproximal lesions?
Yes, I do.
Have you had success using it with interproximal lesions?
We gotta do the follow-up, but hopefully yes.
What is the mechanism that you're using for interproximal lesions?
Well, it was open cavity, so it's like we had a big interproximal lesion, so we were able to access it with a microbrush.
Okay, so my question actually should have been interproximal lesions without marginal ridge breakage.
That was actually, I was going to question that, because I have tried it, but I haven't done the follow-up yet to see. So I did a couple with Superfloss, and then we also did it with placing the separator and then getting in there with the microbrush, but I have no follow-up. And these were not open lesions, they were more like calcified lesions, the incipient lesions. And I was going to ask what the effectiveness is of that, and is it recommended?
Yes, I'm not sure. I mean, there are people that have used it. I've seen it on the net and spoken with people, either using a separator to open up the lesion and then be able to access, and use Superfloss to put the Superfloss through it, put a little dab, and then kind of rub it through, and again rub it through from either side. And you know, the question is that I don't think that there are any studies that show it does or doesn't work, but using it, it's possible, depending on the depth of the lesion, that it works. But it's just a matter of just kind of following through and seeing. I don't know that there's. Does anyone have any other success using it that way? Yes, sir.
I've had at least one case where there were open lesions posteriorly, but there were clearly some interproximals in a 3 or 4-year-old in the anteriors that weren't cavitated yet. And while I applied the fluoride to the posterior region, I also applied it to as much best I could to the anteriors. That child came back with evidence of blackening between the anterior teeth, so I assume it had some caries arresting effect on the anterior teeth.
Yeah. I think it's a matter of just getting the proper techniques together, and it's just visually to see how much blackness, how much the material looks dark. Yes, Christine?
Well, that's what I had the question. You know, we see the distal lesions on the E's, and you just start to see the spread on the 6s, and how, I mean, to me, that would be a great thing if it works, if you restore that E with the glass ionomer, but before you do it, put a little, you know, I would love to see if that's something that's worthwhile, stop the progression, or does it have to be cavitated versus a decalcified lesion?
We were talking earlier about if you take a maybe 9 or 10-year-old that has a second primary molar, that has some caries there, and a lot of times say, gee, it's going to exfoliate in a year, should I restore it, not restore it? And that's not unreasonable to go ahead and the first primary molar's fallen out, and you don't want to let it go a year or a year and a half and have it abscess, but this would be a possibility to use it in that circumstance, to go ahead and put some of the SDF in there and to arrest the caries versus doing restorations that are going to last a year or something like that. So that's something that I forgot exactly what we were talking about, but that's you know, a possibility to use. Just like you know, many times you have a second primary molar and you have caries there right up against the first permanent molar. And leaving it there just means you have a hole there that's going to get caries on the permanent tooth. Food will get caught there, but if you use SDF, or you know, what we really do now is we'll do a prep and we'll do a glass ionomer just to give fluoride to the mesial surface of that first permanent molar. What about age-wise? What is the youngest that anyone has used the SDF for? No one really.
2-year-old. On a 3-year-old.
2-year-old, yeah.
2.
Yeah. So, I mean, I've seen it documented that people have used it as young as 12 or 14 months on some kids that have early childhood caries on the 4 anteriors. Basically, the molars are just erupting. Again, you know, I think when you talk about the safety part of it is, you know, you're talking about someone who was very small and, you know, less pounds versus someone who is a 2-year-old, and it has to be used judiciously, and when you wipe it on teeth and rub it into those areas, just to make sure that there's not a lot of excess on other areas or on the soft tissues, and to make sure they don't ingest it, because it is, while it's not toxic for a young child who's that age, it's a very, very high concentration. Yes, Sarah.
Just to add to that, in terms of safety, do we know with such a high concentration of the silver, what tissues and organs is the silver deposited in? Do we know how it's excreted from the body? Or questions, I guess, to tail end on the safety issue.
Mm-hmm. Does anyone have any, information as far as the where it's absorbed, excreted, etc., as far as the silver? But it's very, very valuable. I'm not sure if do we have a policy on SDF in there?
Currently, and I asked if I could share this information from Ed Rick, who's the current chair of the Council on Clinical Affairs for the Academy of Pediatric Dentistry. And currently, the CCA and the CSA are working on a joint policy on silver diamine fluoride, as well as the evidence-based group is also currently working on a guideline or a clinical practice guideline. And those are two things that should be, I believe, should be available in May come our annual session. So something to stay abreast on and to look for from our academy.
Mm-hmm, mm-hmm. Well, given its use historically, right? Throughout the body, some very sensitive areas, it would seem to me, is rather inert.
Well, yes, but you don't know.
I know.
Yeah.
But that's what it would suggest anyway.
Yeah. So.
Can I just ask a question to the group? Not everybody raised their hands. I realize we have residents here as well, but I mean, I wouldn't expect all of them. All the residents. But in any case, not everybody raised their hands. Any particular reason why people have not been using it? I mean, is it something about the practice? Is it something that you yourself have a problem with? I don't know. I mean, it'd be nice to get different feelings on this thing. This miracle drug.
I think a big part of it has to do with the population you're treating.
Right.
Is a big part of it. So private practice, certain private practices, you're going to see less need for it.
Yeah.
Residency, there's no doubt there's more of a need. Certain socioeconomic areas, there's more of a need. Look, behavior management is part of it. Patients you're comfortable treating versus patients you're not comfortable treating. So there's that gradation there, and it's really need-based, I think, that we've seen, plus training. I think part of it is it's newer, so it's what you're comfortable with and what you've been doing previously, and if it's worked.
Have you had any negative responses from the parents? Surprised, like, what is this, even though you prepared?
So I agree with John. I think a big part of it is patients who need general anesthesia. That's your big selling point from the standpoint of the benefit of it. Aesthetically, there's nothing to sell in it. It's not aesthetic.
No.
Clinically, if the treatment can be completed with the patient being cooperative, the question is why am I going through that versus having white filling? So that's the hard sell. So I really think the population that you're going to be treating with it potentially is, the options are far more limited of what you can do. Versus it hasn't gotten to the point, I don't think yet, where it's just, let's not treat decay and let's do this all the time.
I think we also have, like at the Holyoke Health Center in Western Mass, we have the Lutheran NYU residency. Surprisingly, a lot of the patients refuse the treatment once they see how it actually looks. And these are kids that are even going under general anesthesia. The parent just want to go under GA, but get the white filling. I don't know if that has to do with the socioeconomics and the educational levels, because we do have a lot of migrant population in Holyoke, but we've had at least a 70% refusal to apply SDF.
And do they realize that eventually it can be restored?
Oh, yes.
Yes.
But to see that picture of the black tooth, they would say like, no.
Mm-hmm. Very interesting.
So don't show them the picture.
Yeah. Yes, they.
Arnie, as we go through the indications for the procedure, I think we're going to get to the point where we're going to sort all this out, as Sarah said, in particular through the councils and committees of the American Academy of Pediatric Dentistry. But as you see articles, like the article in August in the New York Times, that's going to temper it. The public media and the social media are going to start tempering those indications. And it'll be interesting to see how we react to either a positive, which I feel it will be, or a negative pressure against the indications that we lay out for the procedure.
No, I think that, and we have had calls about it, and I think Wes has been the one who has, communicated most, maybe Danya with one of them. But when you say, that we can do the restoration, your child will be comfortable, and we'll do a restoration that is aesthetic, and we can do the silver diming, but your tooth will be black and eventually have to restore it. I don't think anyone has said, oh no, I want that SDF. They've always said, oh, you can do it, and the kid will be happy, and sure, just do the restoration. So I think it's the media makes up that pediatric dentistry is very difficult, it's negative, it's a bad experience, and with the proper behavior guidance, most of these kids can be restored. I'm not talking about the early ECC, but most of the kids that parents are 3 and 4, and gee, why do I have to have a filling? Most of the parents have opted to have regular restorations.
We've used it also for a bit of a different sort of indication. Young children with permanent first molars having large cavities, trying to avoid getting into a pixification or a pixogenesis. We've applied the SDF to arrest the decay, gave the teeth some time, hopefully for some secondary dentin to form, and then actually managed to restore these teeth without doing root canals.
Yeah, no, that's partially erupted teeth that you don't have good access, that come in dysplastic. Yeah, there's no question. There are, I think, as more and more people do it, and as you talk and everyone listens, I think there are more and more areas where we would like to use it. And again, the population looking at it and saying we can use it for everything, no. But there's, 30–40% of certain types of lesions that it's very appropriate to use. And when you talk about using the SDF on this, you're talking about like indirect pulp caps. People are talking about the Academy of Indirect Pulp Therapy. You're talking about the whole crown, other things that will arrest and stop the caries process. But again, that doesn't mean that you're not going to have to do something later, but it is a great service for those teeth that you go in, you open it up, and you do a pixification, and you have a shorter root or whatever. So that is a very valid thing. And again, Christine was talking about with special needs. Anyone has, yes?
In terms of follow-up, so people that are using this, when are you having the patients come back? Is it 1 week, 1 month, 2 months, or is it just a case-by-case basis? What are people
right
doing?
Now, it is a case-by-case. A lot of times we offer it to patients that are on a list to be treated under general anesthesia. And we see them in a week for post-op in case the parents have any questions or any comments about the darkened lesions. And we typically will get them treated before the 6 month, but if there is any need, we plan to reapply at the 6 month interval, because these SDF treatments don't last forever, because you have breakdown, and I think you would see some of the black staining moving away, and then you have to reapply to kind of seal off that lesion again.
So it doesn't make sense to have them, some people were saying they do it every month or every couple months. Is that too much in terms of fluoride, concentration of fluoride or the silver exposure?
Well, the literature has said that if you have a 1 week interval, if you use up to 2 drops, that is fine. That's below the any safety concerns. But I mean, I wouldn't use it every month, because if they're coming in to monitor the lesion, it shouldn't be breaking down within a month.
Okay.
My experience is that you don't have to use it more than a couple of times, a couple of applications. So you might see them follow up for a week later, 2 weeks later, or a month later, and then that's it.
Yeah.
And then you're monitoring them for what your next step is going to be, whether it's going to be restoration or whatever the scenario might be.
Yeah. I think David mentioned that also, that, and I think part of it is as you start to use these things, You see the lesion, you use it, and then a month later you look at it and you say, gee, it's hard, or gee, it could use a little bit more, and you get a feel for it, like any restoration or any procedure we do, what are you going to do in the future? So I think initially, most people follow up in a month, and depends what it looks like. They might do it more, it might be very hard and forget about it. They might another 2 or 3 months, and then 6 months. So again, I think part of it, especially if you're just starting to use it, you want to see what the effect is over time.
We're doing actually 2 applications within 1 week. So we put the first application, bring the patient back in 1 week, do a second application, and then just put them on a monitor every 3 weeks until they go.
And then you're doing a 6 month, you do 1 week, 1 week, and then 6 months.
This 3-month fluoride application and monitor.
3 months.
Hopefully they will end up in GA as soon as possible. So our wait list is very long.
Yeah.
What about fees? We can't be too
Yeah.
detailed.
So are people charging
Cost.
per tooth or per application?
Application.
Applications? Yeah. I've seen, again, on the net, I've been researching this over a while, that there are certain states that Medicaid does cover it, and they cover it on a per tooth basis. That's why people are charging per tooth. As far as fees, they range from what a fluoride treatment is without saying dollars. You're not supposed to say dollars, but it could be a fluoride treatment, it could be something more. But if people are doing 4 or 5 teeth, they're charging 4 or 5 procedures. But that also means that that procedure is not doing that. You're going to see them in a month, you're going to see them in 3 months, you're going to see in 6 months, so it's monitoring that, and that usually is included in that 5 or 6 teeth that you're charging for at the time. Other people will do one visit and charge 40, 50 bucks, whatever it could be, and then they come in again, and they will charge again for that treatment, again for the other. So it just depends on what the needs are and what the insurance companies are trying to look at, especially since it's starting to be approved more.
That was my question, is how the process is to get private insurances to consider a code. that
Well,
they'll review.
because it's off-label, they haven't done anything. But now that it's possible, and there are certain states, and I don't know exactly specifics, certain states that are charging or paying for it for Medicaid, it's cheaper for them to do 200 bucks here or there than going to the OR. So I think more and more people will look at it, and
Massachusetts
not
covered.
Not covered, yes.
I think what you're going to see, Arnie, is the coding process will determine whether or not we'll be charging by the application or by the tooth, and I believe that's in the process of being looked at now.
I was just going to add to that, Dave. Currently, and I asked Dr. Paul Ricciardio if I could share this. He's the chair of the Committee on Dental Benefits Program for the American Academy of Pediatric Dentistry. And the Academy is currently making a request that the code be used on a per tooth basis, similar to as we do for the nomenclature for sealants. So they're requesting an action from CDT that a revision of the nomenclature be made for the application of caries arresting agent specific to a single tooth. So again, to kind of be aware, to monitor, but that's the request being made by the Academy of Pediatric Dentistry at this time.
Yeah, and the only ones that I've seen that they said have approved or have been doing it on a tooth basis. Any other questions or concerns someone might have? I guess the only other, oh yes, please.
Is anyone concerned about when we've applied the SDF and then the patient goes to a general dentist who's not so aware of SDF, and then they're like, oh my gosh, this is a cavity, you shouldn't have been waiting so long, and then the general dentist kind of bad-mouthing the pediatric dentist, or not treating the caries.
Yeah. Well, I think part of it is up front to explain to the parent, what you're doing, and that it will turn out this way, and just making sure that if they do go elsewhere, or if there's some communication back. I mean, if someone goes to another dentist, will ask for records, they'll ask for radiographs or whatever it is, So just to make sure that in the documentation it says, this is what the diagnosis, this is where the caries are, this is what we did, monitored here, it's arrested, and this is what we're monitoring to either restore in 6 months, or if it's an older child in the tooth, to exfoliate, just to monitor it. But you know, I can see that, you know, people look at it and say, gee, how did it get so bad? And you know, that's not the whole story. And whenever we see patients coming in from either general dentist's office, other pediatric dentists, or they've been to 4 and you're the 5th one, there's always a story to it. So I think the answer is to find out and do research into what it is, and that general dentist should do the same thing, contact and find out. But the parent should be informed of exactly what we're doing, why we're doing it, the benefits of doing it, which is the most important, and that what we expect to do a little bit in the future, so they can communicate that as best as possible with the general dentist.
I guess, is SDF, our general dentists in schools, are students exposed to this treatment?
SDF, it's only been approved for desensitizing for a year in the US. So whether people have been using it and importing it from other countries, I don't know. So it hasn't been used very much. And I think just because of the media, people are aware of it more. And I have some, GPs will ask you, my grandson, should I use that or something like that. So they know, but they don't really know as much. And even the pediatric dentists, we should know everything. And I'd say that only a small percentage of people are aware or even open to it. I look at it and I haven't used it for all the years. And Wes and Ronnie and we are in the office. We do restorations on most of the kids. So we're not used to going ahead and say, okay, let's paint this on here and let's restore it in a year from now. But there are many indications that we see that it can be used. So we're looking at it's not going to be used maybe as extensive as others, but we see that there's a certain percentage of patients that we will start to use it and get more comfortable with. And you're talking about people who have been in practice for, umpteen years like Dr. Decini here, or younger people like myself. So I think it's, the people that, and if you look at the forums that, all the new graduates and younger people are looking at it and say, gee, this is a miracle and we should use it. And it's a miracle and it should be used when it's appropriate, but not across the board like everything. Christine.
Well, this is interesting. I'm trying to think back. I had a patient 25 years ago in dental school, one of my patients, and she was recently immigrated from Poland. And I had to kind of do full mouth rehab on her, but I can remember that she had these teeth that were black and hard, and they weren't your typical caries. But none of my teachers, and I certainly ever put it together, but now that I'm dealing with SDF, I'm like, she had SDF or some kind of silver application way back then. I mean, I remember, I did crown and bridge on her, but her caries were not like soft mushy caries. It was hard. Yeah, they were black.
And the rest of the caries just happen sometimes. You have caries and it just stops and it turns black like that without any specific medications.
I'm thinking back, she probably had something, being European. And,
it could be, yes.
Those are the kids that were born with a silver spoon.
I knew it.
She was a 40-year-old little
Well, I knew if I sat next to him long enough, that would come out.
So funny.
Whoops. I think that's a wrap, right?
I think so.
Anyway, I want to thank everybody for coming. I want to let you know, too, that in February 2017, February 8th to be exact, Bert Elstein and Steve Chussett, Columbia, is going to be presenting on effective caries counseling in your practice. Is it possible? How do you do it? And that'll be live streamed. We know for a fact. So where they're actually, no, I'm just saying, they're going to be at Columbia University doing it. We're probably going to have a little party like this as well. In May, we have tentatively scheduled Chris Hughes from Rutgers, Christopher Hughes. In August is Vineet Dar from Maryland. And let's see, we're talking about November. Am I right? Every quarter, it's a quarterly event. Is Deborah Student Pavlovic from Pittsburgh. And we've just booked Paul Casamasimo, we're going to schedule him as a special virtual NED on, he's going to be giving one on the Hall technique. So keep them coming, those cards and letters coming, and and this is all free, by the way, free CE. So.